Hi, I'm Jeanette Benigas, the owner of Fix SLP. Welcome to the Fixing the Coding Chaos series. If you haven't yet, please hit subscribe below. We are trying to reach all of the clinicians off social media, and this is one of the best ways to do it. Let's jump into it. Today, we're talking about schools and educational settings. I think this is a hugely misunderstood part of the conversation. Does this impact schools? People hear CPT codes and automatically assume this is only an outpatient medical setting. But the reality is much more complicated than that. School-based speech-language pathology intersects with Medicaid billing in many states, and even in districts that do not directly bill Medicaid, broader healthcare coding structures can still influence documentation expectations, compliance systems, software platforms, staffing models, and service delivery frameworks over time. While every school district operates differently, it would be inaccurate to assume schools are completely isolated from these conversations. And that leads to the next major question: how would schools implement timed codes mid-year when the new codes start on January 1st? And honestly, operationally, that would be difficult for many districts. School systems are typically built around IEPs, established caseload schedules, group therapy structures, staffing allocations, transportation schedules, and annual service planning. Those systems are not designed to rapidly pivot mid-year into entirely new therapy timing structures. Imagine suddenly trying to reorganize 30-minute groups, push-in services, pull-out sessions, collaborative classroom models, and Medicaid documentation requirements, all after the school year is already underway. That is not a small adjustment. And many school clinicians are especially concerned because school therapy often does not neatly fit into those isolated treatment categories. Which brings us to another huge question: how could mixed school sessions be coded? Because school sessions are often highly integrated. And I've got good news for you. The American Speech, Language, and Hearing Association did not touch 92508. Carry on, folks. You can still do what you've been doing the whole time if you have a group. So any school clinician asking, how exactly are we supposed to separate integrated educational communication services into narrow time billing categories? It's a great question because schools are not just healthcare environments, they're educational environments. The goals are often functional, academic, social, behavioral, and participation-based all at once, which means the structure of the school-based communication intervention may not cleanly align with highly segmented medical-style treatment coding in one-on-one sessions. Let's talk specifically about Medicaid, because another question I've received is, how would school Medicaid billing change? The answer likely depends heavily on your state. Some school Medicaid programs are already highly structured and diagnosis specific. Others operate more broadly under the educational service model. But when the CPT structure changes, states may eventually revisit billing rules, documentation requirements, covered services, and the claim submission process. And that could create major implementation differences across the country. Some states are going to adapt quickly, others may delay. Some may issue extensive guidance, and others might leave districts completely in the dark to interpret the changes on their own. Unfortunately, variability between states is already common in school Medicaid systems, and it's going to make nationwide education of school SLPs and districts very difficult. I'm going to wrap up with one of the last school-related questions I'm getting, which is, will schools need different scheduling structures? And I'd say potentially yes, because school schedules are often built around fixed IEP minutes, bell schedules, lunch periods, classroom access, transportation windows, and legally required service delivery obligations. These future billing structures are going to potentially require these larger timed increments, more segmented treatment categories. Then the districts may eventually feel pressure to reconsider session lengths, maybe even adding in more group models for more leniency. They'll probably start to reconsider scheduling efficacy, documentation workflows, and therapist productivity expectations. That becomes incredibly complicated in schools where clinicians are already balancing massive caseloads, evaluation, Medicaid paperwork, teacher collaboration, IEP meetings, AAC support, and compliance responsibilities. So when school SLPs hear discussions about time treatment structures, many are not just thinking about billing. They're thinking about how could this actually function in schools with real kids and real schedules? And that's a really reasonable question because school-based speech pathology is deeply integrated, highly dynamic, and often impossible to separate into those rigid clinical silos minute by minute, which is exactly why school clinicians are paying close attention to these conversations right now. More will be determined as this continues to roll out. I hope you found this video helpful. If you have more questions, ask them in the comments below. Don't forget to hit subscribe while you're there, and thanks for fixing it.